A woman is crouching in the dark, not lying down, crouching, feet flat on the ground, knees wide, back against nothing. The fire is close enough to feel, but not close enough to see clearly. Around her, 2 or 3 other women are doing something specific with their hands and voices. One is pressing her palms into the woman's lower back with steady, deliberate force. Another is speaking, not panicked, not urgent, just a low, continuous sound that functions less like language and more like a rope thrown into dark water. Outside this circle, nobody enters, not the men of the band, not the older children. This is not a rule that was written anywhere. It is a boundary that has existed for so long that no one remembers deciding it. The woman's body has been doing this, contracting, releasing, building, for somewhere between 6 and 14 hours. She has eaten nothing. She has drunk water when someone brought it. She has not screamed, though she has made sounds that the people outside the fire circle have learned, over generations, not to misinterpret. And here is the thing almost nobody thinks to ask. She will probably be fine. Not because birth was safe in the ancient world, it wasn't. Not because the women around her have medical training in any recognizable sense. They don't. But because what is happening in that circle, the position, the pressure, the voices, the specific knowledge held in the hands of the woman nearest to her, is not improvised. It is the accumulated result of tens of thousands of years of women watching, learning, surviving, and passing on exactly what worked. If this is already landing, subscribe and let us know in the comments where in the world you're watching from. The popular picture of ancient childbirth is one of helpless suffering. A woman alone or nearly alone, at the mercy of a body doing something catastrophically dangerous with no tools to manage it. The story we tend to tell ourselves is that childbirth was almost certainly fatal before modern medicine, that women routinely died in the attempt, that infants died just as often, and that the whole enterprise was essentially a roll of dice that civilization finally learned to rig in our favor, somewhere around the invention of the hospital. That picture is not entirely wrong. Ancient birth was genuinely dangerous. Women did die. Infants died. Some of what killed them could have been prevented by things we now take for granted. Sterile instruments, blood transfusions, cesarean sections performed by trained surgeons on conscious patients who would survive the procedure. But the picture is also, in important ways, badly incomplete. Because the assumption hidden inside it, that ancient women faced childbirth essentially without knowledge, without skill, without anything resembling a system, is not what the archaeology, the comparative anthropology, or the evolutionary biology actually shows. What they show instead is something considerably more layered. A set of physical, social, and behavioral adaptations to the problem of human birth that developed over such a long time and reached such a level of sophistication that researchers studying traditional birth practices today sometimes find themselves looking at techniques that outperform clinical interventions on specific measurable outcomes. Not because ancient women were lucky, because they were, in a very precise sense, good at this. To understand why, you have to start with the thing that made human birth uniquely dangerous in the first place. Because it is not what most people assume. Human birth is hard in a way that is almost without parallel in the animal kingdom. A chimpanzee, our closest living relative, delivers an infant that exits the birth canal facing downward, in the same direction the mother faces. The mother can reach down, guide the infant's head, help it rotate, pull it clear herself if necessary. The entire process, for a healthy chimpanzee in normal circumstances, typically takes under 2 hours. Many primates give birth alone. The mechanics simply don't require assistance. Human birth is different in a way that is directly, specifically, measurably tied to 2 things that happened over the course of our evolution. We stood upright, and our brains got large. Both of these changes happened for reasons that had nothing to do with birth, and both of them made birth dramatically more complicated in ways that took millions of years for the species to develop responses to. Standing upright restructured the pelvis. Walking efficiently on 2 legs requires a pelvis that is relatively narrow in the front-to-back dimension, the shape that allows the femur to sit directly below the body's center of gravity and lets us walk without the side-to-side waddling gait that other bipeds use. But a narrow pelvis creates a birth canal that is, by primate standards, extraordinarily tight. Meanwhile, the brain that was expanding to accommodate language, tool use, and social complexity kept getting larger, and the skull that housed it kept getting larger with it. The result is a birth canal that is essentially exactly the minimum size required to pass the infant's head. Not by a comfortable margin, exactly, within millimeters in many cases. And because of this mismatch, the human infant cannot exit the birth canal facing the same direction as the mother. It has to rotate, descending face forward relative to the mother, then rotating 90 degrees, then exiting face backward. The head exits first, facing away from the mother. Then the shoulders have to rotate again to clear the canal. The infant emerges in a direction the mother cannot easily see or reach. This rotation, which researchers call the mechanism of labor, means that a human mother attempting to assist her own delivery faces a genuine mechanical problem. If she reaches down to guide the infant's head and pulls in the most intuitive direction, she risks pulling against the curve of the birth canal. She risks pulling the infant's neck backward against the direction of rotation. The injuries this can cause range from nerve damage to death. This is why, across virtually every documented human culture on Earth, birth is not a solitary act. It is attended. The anthropologist Wenda Trevathan, who has spent decades studying the evolutionary origins of human birth assistance, argues that the need for help during delivery is not a cultural preference or a sign of weakness. It is a biological consequence of the specific evolutionary path our species took. The attended birth in this framework is not an invention of civilization. It is older than civilization by orders of magnitude. It may be as old as anatomically modern humans themselves. The attendants brought specific things. Not technology in most cases. Not instruments. Knowledge, held in hands, eyes, and accumulated experience. And the first and most fundamental piece of that knowledge was position. Modern clinical birth in most Western countries takes place with the mother lying on her back, legs elevated, in what is called the lithotomy position. This position became standard in European obstetrics largely in the 17th and 18th centuries, associated with the rise of male physicians entering a space previously occupied entirely by female midwives. It optimizes the attendant's line of sight. It makes instrumental intervention easier. It is, in important ways, designed for the convenience of the person delivering rather than the person giving birth. It is also biomechanically one of the worst positions for the laboring woman's body. When a woman lies flat on her back during labor, the full weight of the uterus presses directly onto the inferior vena cava, the large vein that returns blood from the lower body to the heart. This compression reduces blood flow. It can drop blood pressure. It reduces the oxygen supply reaching the placenta. It closes the sacrum, the triangular bone at the back of the pelvis, against the surface beneath the woman, preventing it from flexing outward in the way it is designed to flex during delivery. The sacrum is not a fixed structure during birth. It moves. When a woman is in an upright position, crouching, kneeling, standing, or on all fours, gravity pulls the sacrum downward and backward, increasing the internal diameter of the pelvis by a measurable amount. Studies comparing pelvic outlet dimensions across different positions have found that upright postures can increase the available space in the birth canal by as much as 28% compared to lying flat. Not a marginal difference. More than a quarter again as much space for the infant's head to pass through. The women crouching around fires in ancient camps. The women laboring on their knees in documented traditional cultures across every inhabited continent. They were not doing this because they lacked the option to lie down. They were doing it because it works better. The knowledge had been selected for over thousands of generations of women watching other women give birth, noting what produced faster labors, fewer complications, and more living infants, and keeping that knowledge alive through the only storage system available: memory, apprenticeship, and practice. This is where the midwife enters the picture, not as a modern professional role, but as something much older and considerably harder to define. In essentially every traditional culture that has been studied in sufficient detail, there is a category of person, almost always female, almost always older, who holds specialized knowledge about birth. The specific knowledge varies by culture and environment. The social role varies. The rituals surrounding it vary enormously. But the structural fact of the specialist, the person to whom a laboring woman is brought, or who is summoned to her, appears with a consistency across human cultures that researchers have come to treat as a human universal. If this video is giving you something to think about, subscribe and turn on notifications. It helps us keep making content like this. The specific skills these specialists held were not mystical. They were practical. And some of them, examined from the outside, look almost surgical in their precision. One of the most documented and most important was the management of what happens to the perineum, the tissue between the vaginal opening and the anus, as the infant's head crowns. This tissue stretches during delivery to a degree that is, under normal circumstances, remarkable. But when it is stretched too fast, or when the infant's head is in a less than optimal position, it tears. Perineal tears in childbirth range from minor to severe, and severe tears, which extend into or through the anal sphincter, were, before surgical repair became available, a source of lifelong disability and chronic pain. Experienced midwives in documented traditional societies applied warm compresses to the perineum during the pushing phase. They applied oils, olive oil, animal fat, plant-based preparations specific to the local ecology. They used their hands to apply counterpressure against the emerging head, slowing the delivery at the critical moment and allowing the tissue to stretch gradually rather than tearing under sudden force. These techniques, particularly the warm compress and the manual support, have been studied in clinical trials in modern obstetrics, and they work. A 2013 Cochrane review found that warm perineal compresses significantly reduce the rate of severe perineal tears and reduce pain. Some hospitals in Northern Europe had largely abandoned these techniques by the mid-20th century. They are now being reintroduced, based partly on evidence from exactly the kind of traditional practices that clinical medicine spent a century regarding as primitive. The position of the infant mattered just as much as the position of the mother. An infant presenting with its head in the occipito-anterior position, face toward the mother's spine, moves through the birth canal along its most favorable curve. An infant that has rotated into the occipito-posterior position, face toward the mother's abdomen, has a larger diameter presenting to the pelvis and tends to produce longer, more painful, more complicated labors. This is what is commonly called a back labor, and it is significantly harder than a standard delivery. Ancient midwives developed physical techniques for addressing this. Documented in traditional cultures from sub-Saharan Africa to the indigenous Americas to South and Southeast Asia is a practice that modern researchers have come to call external cephalic version, though the women performing it did not use that term. It involves placing the hands on the outside of the abdomen and applying sustained, specific pressure to encourage the infant to rotate into a better position, either before labor begins or during early labor while there is still room to maneuver. The technique requires knowing what you are touching. It requires being able to feel, through the abdominal wall, the difference between the infant's head and its buttocks, the direction it is facing, the position of its spine. This knowledge, tactile, built through years of attending births and feeling dozens of pregnant abdomens, is the kind of knowledge that cannot be written down. It exists only in hands that have done it enough times to develop the sensitivity required to do it correctly. Archaeological evidence for the existence of birth specialists goes back further than most people realize. At the Neolithic site of Çatalhöyük in modern Turkey, occupied from roughly 7500 to 5700 BCE, excavations have uncovered clay figurines depicting a female figure in a seated or squatting position, flanked on each side by what appear to be large felines. The figure is broad in the hips, voluminous in the abdomen, and positioned in what multiple researchers have interpreted as a birth position. Whether this specific figurine represents a goddess, a birth attendant, a symbolic acknowledgement of the dangers of labor, or something else entirely, is genuinely contested. But the physical posture it depicts, squatting, wide-based, supported, is consistent across thousands of years of artifacts from cultures with no contact with each other. The pain of labor was managed too, not eliminated, but managed, through means that were, in their way, sophisticated. Specific plant preparations appear in the ethnobotanical record across cultures with remarkable consistency. Blue cohosh, a plant found across eastern North America, was used by multiple indigenous cultures to stimulate contractions during prolonged or stalled labors. Ergot, a fungal growth on rye grain, was used in European traditional midwifery to stop postpartum hemorrhage. The effect comes from ergotamine, a compound that causes powerful uterine contraction and which remains a component of modern drugs used in exactly the same clinical context. Raspberry leaf preparations appear in traditional midwifery traditions across Europe, Asia, and the Americas, used to tone the uterus in the weeks before delivery. The active compounds are real. The mechanism is debated, but the plants were not chosen at random. Willow bark, which contains salicin, the precursor to aspirin, was used across multiple traditional medical systems for pain management broadly, and there is ethnographic evidence for its use during labor specifically. The dosing was imprecise. The pharmacology was not understood in any formal sense. But the compound was there, in the preparation, and it worked to the degree that it worked. Not because of belief, but because of chemistry. The management of the immediate postpartum period was as important as the delivery itself, because the single largest source of maternal death in childbirth, across all of human history, and still today in settings without adequate medical care, is not the delivery. It is what happens after it. Postpartum hemorrhage, the failure of the uterus to contract adequately after the placenta is delivered, allowing the blood vessels that fed the placenta to continue bleeding into an open space the size of a dinner plate. Without intervention, this can kill a woman in under an hour. It accounts for roughly a quarter of all maternal deaths globally even today. Ancient birth attendants had techniques for this. The first was immediate skin-to-skin contact between the mother and the infant, with the infant placed directly at the breast. This is not a comfort measure. It is a biological trigger. Breastfeeding stimulates the release of oxytocin from the posterior pituitary gland, and oxytocin causes uterine contraction. The mechanism is the same one that pharmaceutical oxytocin, Pitocin, in the modern clinical context, exploits. Putting the infant to the breast immediately after delivery was, in effect, administering the most available version of the most important postpartum drug, drawn from the mother's own endocrine system. The ergot preparations mentioned earlier serve the same function through a different route. Uterine massage, firm manual compression of the fundus of the uterus through the abdominal wall, also stimulates contraction and reduces bleeding. This technique is documented in traditional midwifery practice across cultures and remains a first-line intervention in modern obstetric emergencies. None of this made ancient birth safe in the way modern obstetrics has made birth safe. The numbers are not comparable. Estimates of maternal mortality in pre-industrial populations vary widely depending on the source and methodology, but figures in the range of 1 to 2 deaths per 100 deliveries appear repeatedly in historical and archaeological analyses, compared to roughly 8 per 100,000 in contemporary high-income countries. The ratio is not close. Women died from obstructed labor that a cesarean section would have resolved. They died from infections that antibiotics would have cleared in 3 days. They died from blood loss that a transfusion would have reversed. These are real deaths. They are not made smaller by noting that the surviving women had skills. But the skills existed. They were real, they were accumulated over an enormous span of time, and they were effective within the limits of what was available. The woman crouching by the fire, attended by people who knew what they were doing, was not at the mercy of ignorance. She was the beneficiary of knowledge that her species had been building, testing, and refining for longer than agriculture has existed, longer than pottery, longer than anything we typically point to when we describe the beginning of human sophistication. The sophistication was already there. It was in the hands of the women around her. It was in the position her body had been guided into. It was in the specific pressure being applied to her lower back, which, research on labor support now confirms, reduces the perception of pain by stimulating the same nerve pathways that the descending fetal head compresses, offering a form of natural counterstimulation that works through the same gate control mechanism that acupressure and epidurals both, in different ways, exploit. She did not know the mechanism. She didn't need to. The women who taught the women who taught her had learned that the pressure helped, and so the pressure was applied, and it worked, and it was remembered. There is one more piece of this that the popular picture almost always leaves out, and it may be the most important one. Birth in the ancient world was not only a physical event, it was a social one, and the social architecture built around it. Who was present, who was excluded, what happened in the hours after, was not decoration. It was functional. The field of modern obstetrics has a term for continuous labor support: the doula. A doula is not a midwife. She does not perform clinical assessments or manage complications. She is present. She speaks. She touches. She is the continuous human presence that communicates. Without necessarily using those words, you are not alone. This is survivable. Other women have been here and come through. The evidence for what this actually does to birth outcomes is not subtle. A Cochrane review analyzing data from over 20 randomized controlled trials found that continuous labor support from a trained companion reduced the rate of cesarean delivery by 25%, shortened the duration of labor, and reduced the use of pain medication. 25%. If a pharmaceutical compound produced that number, it would be considered a major clinical breakthrough. What produces this effect involves cortisol. Labor is partly governed by a hormonal balance between oxytocin, which drives contractions, and cortisol, the primary stress hormone. Cortisol in high concentrations inhibits oxytocin. A frightened, isolated laboring woman produces cortisol. Too much of it stalls contractions, extends labor, and contributes to what clinicians call failure to progress. A woman who feels safe and attended produces less cortisol. Her oxytocin works more effectively. Her labor moves forward. The women around the fire were not simply offering comfort. They were, in a measurable biochemical sense, keeping the labor moving. Ancient birth attendants could not have explained the mechanism, but they could see it. A woman laboring alone labored longer and worse. The observation was sufficient. The practice was maintained. The structure of exclusion served the same function. The rule keeping men and uninitiated others outside the birth space was not only about custom or the preservation of female knowledge, it was protective of the hormonal environment. A laboring woman who felt exposed or observed by people she felt judged by was a woman whose stress response was activated. The enclosed, female-only birth space was, in part, a cortisol management technology, one that produced real effects, across cultures separated by oceans and millennia, because the underlying biology is the same everywhere. The postpartum period was governed by its own practices, and these too were not arbitrary. In documented traditional cultures across sub-Saharan Africa, South and Southeast Asia, the indigenous Americas, and the Pacific, there is a remarkably consistent institution, the postpartum rest period. The specific duration varies, 40 days here, 6 weeks there, but the structure is nearly identical across societies with no historical contact. The new mother is relieved of her usual labor. She is fed warm, caloric, protein-rich food. Other women manage the infant through the night, bringing it for feeding but handling the rest. She does not return to full function for weeks. This is not indulgence. The uterus requires roughly 6 weeks to fully involute, to contract back toward its pre-pregnancy size, and for the internal wound left by the placenta to heal. Before that healing is complete, physical exertion can trigger renewed bleeding. The new mother's immune function is suppressed. Her sleep debt accumulates at a rate that produces measurable cognitive impairment within days. Ancient communities that enforced postpartum rest were managing a genuine physiological reality their accumulated experience had taught them to take seriously, without any formal understanding of why. The women who returned too soon to heavy labor had worse outcomes. The communities noticed. The rest period was protected. The honest version of this story holds two things at once. The knowledge was real. Some of what was done was also wrong, and some of what was wrong killed people. Colostrum, the thick, antibody-rich first milk produced in the days before mature breast milk comes in, was in many traditional cultures considered inedible. Infants in some documented societies were fed pre-chewed plant foods or animal milk in the first days of life, while the colostrum was discarded. From the outside, this looks like a serious error. It is. Colostrum is extraordinarily rich in immunoglobulin A, which coats the infant's gut and provides passive immune protection against the specific pathogens in the local environment. The infants who didn't receive it were more vulnerable. There was no way to know this without understanding the underlying mechanism, and that understanding only became available recently. Ancient birth was not a catastrophe managed by ignorance, but it was not a golden age of natural wisdom either. It was something more precise and more human, a body of knowledge built carefully over an immense span of time by people paying close attention to what worked, limited by what they couldn't see, doing something genuinely remarkable within those limits. The woman by the fire survives the night. By morning, the infant is breathing. The women around her are doing specific things with specific knowledge, and those things are working, and the knowledge will be passed on. She does not know the name of the hormone that made the pressure on her back reduce the pain. She does not know the immunological function of the milk she is about to produce. She knows the women around her know what they are doing. She knows women have done this before her and come through. For most of human history, that knowledge, held between people, passed through hands and voices and presence, was enough to bring most of them through. Not all, never all, but most. Every woman alive today is descended from a woman who survived this. In a cave, in a grass shelter, in a mud brick house, in the dark, before anyone had invented a word for what the women around her actually knew. They knew. It was enough. Here we are. Thank you for watching. More videos are on your screen now. And if you haven't already, subscribe. We'll see you in the next one.